everyone. I'm Dr. Shweta Marathe, and today we are going to be talking about third nerve palsy. So, what is the third nerve palsy? So, it is basically the oculomotor palsy. The third cranial nerve begins in the midbrain at the third nerve nucleus and the Edinger-Westphal nucleus. It passes through the midbrain into the brainstem, comes out of cerebellar peduncle into the cavernous sinus, and then into the orbit, where it will divide into superior and the inferior branch. So, what does this oculomotor nerve supply? It supplies the extraocular muscles of the eye apart from the lateral rectus and the superior oblique muscle. There is also a branch which goes to the levator palpebrae superioris and also the ciliary ganglion. So now the causes of a third nerve palsy would depend on where the nerve is involved in its course. So it would be divided into a nuclear, fascicular, subarachnoid space, cavernous sinus, and orbital apex. In the nucleus, the commonest cause is infarction, hemorrhage, neoplasm. In the fascicle, it is the infarction, hemorrhage, neoplasm, and demyelination. Subarachnoid space would be in aneurysms of the internal carotid, posterior communicating, basilar, microvascular causes, neoplasm, meningitis, herniation, and trauma. In the cavernous sinus, it's mainly due to neoplasm, inflammation, aneurysms, microvascular thrombosis. And in the orbital apex, it's mainly due to trauma, inflammation, neoplasm, and infection. So now, how do the patients present? The most common presenting symptom of a patient with a third nerve palsy is ptosis. Now, ptosis may be partial or complete. There would be diplopia, which is more common in incomplete ptosis or in the recovery period. There would also be decreased adduction, elevation, and depression. The eye will appear to be outward and depressed. Pupillary dilation may or may not be present. So, in the first case on the left upper side, you can see it is due to a diabetic third nerve palsy with a complete ptosis and the eye is outward and depressed. The second one is due to myasthenia gravis. You can see ptosis and there is a slight bit of an exo in the patient. The third patient is due to a cavernous sinus thrombosis. So now how do we manage? So now basically when a patient comes to you and you are suspecting a third nerve palsy, you have to make sure or you have to divide it broadly whether it is isolated or non-isolated. If the third nerve palsy is present with other cranial nerve features or any other signs and symptoms, systemic features, then it may be due to the midbrain involvement, cavernous sinus, orbital apex, or any systemic causes. If the third nerve palsy is isolated, then you have to look at the pupil. If the pupil is spared, or the pupil is not spared. If the pupil is involved, that it is mid-dilated, then you will have to proceed with neuroimaging. If the pupil is spared, then you will have to do the eyelid evaluation and extraocular muscles evaluation. If there is a complete lid occlusion, and most probably if the patient is diabetic and hypertensive according to history, address the vascular risk factors and then the patient would recover in 2 to 3 months. If there is no history of diabetes or hypertension, you have to monitor the pupillary involvement and the patient may require by neuroimaging if the pupil involvement occurs. If there is a partial lid occlusion, then you'll have to do a CT angiogram to rule out any aneurysm. Further management would involve diplopia management in case of, like in this patient, you can see on the right glass, you have given a frenel prism, injection Botox to the lateral rectus to prevent contracture, usually done in the first 2 to 3 weeks, crutch glasses for ptosis, pilocarpine for photophobia, and surgery, you have to wait for 6 to 12 months if there is no spontaneous recovery. This would be recommended for further reading and more comprehensive details about the third nerve palsy. Thank you.